The next presentation is from the South Korea. Posterior endoscopic cervical foraminotomy, basic steps and case-based learning. Dr. Kim.
This is my journey, endoscopic, very personal journey for me. Started the transplant endoscope very first, 2006, 20 years ago. Regarding the cervical posterior cervical foraminotomy, I did the very first case in 2012. And let's talk about the complication related to anterior spine surgery. So you might have sort of the experiences. Sometimes annually, I have to guard a sort of revisional serious complication as for ruptures, the running perforation, etc. Right. So all of these cases I manage troublesome, right? So also regarding the implant, so one of the artificial disc is a very good sort of the treatment solution for cervical disc pathology, but it's not really common. So you can find this sort of the osteolysis finding related to the artificial disc have to be divided by the fusion extension. So if it is possible, I love to adopt the endoscopic cervical foraminotomy, even though it cannot be the perfect, the final way to treat the patient. This is the learning objective today about the posterior cervical foraminotomy. Yes, we need to identify the landmark, basic landmark for studying the cervical foraminotomy. We need to understand the indication, how to conform the finalize the surgical procedures with the full decompression. Explain every single step of the endoscope. So, because the basic all procedures are very similar with that of the posterior microscopic tubular cervical foraminotomy, to explain the endoscopic foraminotomy, I love to use this tube-based surgery together. This is the endoscopic, the nomenclature of endoscopic spine surgery. You can find the cervical part, myelopathy, radiculopathy, right? I'm going to focus on the radiculopathy, treating the foraminotomy and discectomy. So, proper the choosing appropriate endoscope is also important in case of radiculopathy. I think the regular discoscope doesn't help, but if you want to decompress the canal and some sort of the wide, the range of the foraminal senses, so big scope is going to be better, I think. Also, anatomy is so crucial. Please review sort of this kind of paper about the foraminal cervical, like the nerve root, and the sort of the anatomy, uncovered joint, and the foraminal height and width. This is one of my friends' paper focusing the anatomy evaluation of endoscopic cervical foraminotomy. This is basic phases in the OR. So I don't describe all the steps from the 1 and 10. This is basic, truly basic. You can find the tube, the endoscope. Basically, it's the same in the name of the tube, but the instrument is totally different, as you know. And choose the appropriate endoscope. For endoscopic spine surgery, you can also see some sort of the detailed cervical anatomy, not only the foramen, but also the spinal shape and the thickness of the spinous process. One of the big advantages of endoscope, in case of a thick, deviated spinal process, tube surgery is a little bit challenging, but endoscope goes well, very well. I have been asked about you use this kind of the clamp or the position and the horseshoe headrest. I think that for the learners and the surgeons who are doing the very first foraminotomy, this kind of Mayfield clamp gonna be helpful, but it's not mandatory, right? Because distraction is possible. Positioning is more feasible for surgeons. And the phase 2 is marked proper incisions and place the tube and cannula. I don't recommend use the K-wire, just make incisions with their blade. all the way down to the fascia and bring the tube, cannula, followed by the cannula, right? Also, this is one of the small tool. So long-lasting, the surgery is your shoulder and surgeon's ergonomy is so important. So I'm not big fan of this kind of the table-mounted arm, but if you have, you can also use that table-mounted arm. It's not mandatory. So everybody recognize and identify the very first landmark, named the Y point and V point. This is the landmark of superficial when you start the endoscopic foraminotomy. This one and this one. So I'm going to compare the microscope tube and endoscope for the phase 4 lateral hemilaminotomy, cranial and caudal side, like this. And regarding the resection of the medial facet, we have been told, please preserve the facet joint as much as possible, less than 50%. But I will say sometimes we need to resect more than 60% if we need it. Rheum flavum removal. Yeah. Once you finish, end up the laminotomy, rheum flavum removal test is being followed. But remember, the layer of the flavum and cervical foramen, the lamina is so thin. Right? Is very thin compared to that of the lumbar spine. Minimize the bleeding control. Usually it's not be challenging because majority of small bleeding comes from the foramen. It's going to be controlled by the pressure and sort of the gel foam, etc. So identify the nerve and the lateral border of the spinal cord is also very important. The procedures for foraminotomy is widen the foramen, but you are advised to look at the lateral border of the cervical myelum, not to make the mistake, right? It's just simply similar to that of when we do the interlaminar endoscopic lateral decompression discectomy. Surgeons are advised to look at the lateral border of the traversing nerve root, just like the same in the case of the foraminotomy. The target is the decompressed exceeding nerve root, but I strongly recommend you have to see the lateral border of the cervical myelum. Look at this. Compare the microscope view and the endoscope view. Sometimes we see the double root, right? Conjoined root and some sort of anomaly. So, and by the endoscope control, it is much more visible than the microscope. Look at this. You can see the lateral border of the cervical myelum and broad, wide, the sensory, and that is motor fiber. One of my the senior's friends, when he did the discectomy, this motor fiber usually running underneath the sensory. So if you didn't recognize the detailed anatomy, you might bring knife, resect the motor, because you recognize motor fiber, something like this, the rupture disc, right? This is very, very important when you do the cervical discectomy. Also, adequate foraminotomy in case of stenosis or calcified disc. Yeah. Remember the anatomy, so length and height of the foramen and how much you have to decompress from the border of the cervical myelum is so crucial. You have to drill. You have to drill this 3 mm and 4 mm bar. You can measure how much you already decompress from the border of the cervical myelum. One of the common challenges and problems in the cervical foraminotomy is regarding facet resection and bleeding issue and the nerve. Yeah, this is the description how this can be addressed and avoided, right? So let's jump to the case. Mostly interest. The case-based learning is always meaningful for surgeons. Look at this, he's 77 years old. He already had the lumbar, the decompression. She complained with left side cervical myelopathy, right there. So the X-ray doesn't have the specific problem. I love to measure the basic parameters. Look at this. no cord compression. Look at the foramen, yes. Between the 6, 7 level, there's sort of a protrusion disc and the stenosis. The tip of SAP pinching, finding the foramen. So I love to evaluate every single patient city, especially in the cervical spine. I'm gonna define the margin from the medial to lateral, how much bone decompression, how much distance from the tip, medial tip of SAP, right? I measured 6.5 mm from the medial tip of the SAP for proper decompression, right? Let's go. Regarding the foraminotomy, especially 6, 7, and 71, I love to use the navigation because, because of the short neck, sometimes it's not visible in CM fluoroscope. Of course, we can identify the level by the AP fluoroscope. This is the trajectory first. Incision should be made along the medial border here. This is the oral walk floor. Arm scan. Look at this. So likewise, a lumbar spine, it is very crucial. Don't waste your time to prepare all the soft tissue, right? Once you identify the imperforated edge of cranial lamina, bring the scope, remove the bone step by step, and then identify the V point. Then you can see this some sort of the medial facet joint there. So this is action of rotation of the scope. Now the 11 to 12 o'clock is cranial. By rotation of the scope, we can get a wide vision to underneath the foramen, right? This is one of the best tools of an endoscope to save the facet joint as much as possible compared to the microscope surgery. Rotation again. Yes, we can see the tip of SAP and joint there. So how much decompression to cranial to caudal? So love to identify the pedicle, right? From the medial to lateral, yes, we can measure preoperatively 7 mm from the lateral border of the cervical myelome. How much to cranial caudal? That is simple, pedicle to pedicle, right? So many of my Korean colleagues, in case of the disc height collapse, they don't hesitate to resect the partial pedicle partially. Partial pedicle, again, some surgeons love to partial pedicle every single case of cervical foraminotomy. I do it selectively, but yeah, please, this kind of the action of partial pediculectomy, if you need it, it is one of the perfect manner of the decompression. Yes, measure, that's going to be 7 mm from the lateral border of the cervical myelome, right? This is V point. I measure the angle and the distance. You can see the nerve root and the sac by sac, find a disc itself, right? So this is outcome, skin to skin, 15 minutes, neck pain and arm pain, 0. Let's see the post-op city. Some surgeons, oh look, evaluate patient, the city too many. Yeah, we don't have the post-op city is not mandatory, but this is one of the good tool to increase your learning curve. You can learn the you can reflect your surgical performance by the images, right? So target post-op city exactly same with the pre-op targeting, right? So let's go to the another case, a little bit more challenging, 71. This is the sudden onset sort of paraplegic because of the hemorrhagic, hemorrhagic facet there, left side, the 71. Likewise, the other previous case, the CT junction is a little bit challenging to identify. In case of open, you can see this spinous process C7. Never miss the location, the level. But in case of the CT junction by the endoscope, yeah, navigation works very well. Right. Look at this. Regarding the drain, I always decide whether I want to put the drain or not once I finish the endoscopic decompression. Yeah. The other case, a little bit common, 5, 6. Foraminotomy is most of the common level, right? Unilateral foraminostenosis. Sometimes radiologists report there's no obvious finding, but in case of the symptoms related, I love to evaluate this kind of dynamic positional MRI. This is the problem. So done, and I'm gonna highlight how it's going on over the years and years. You can see the post-op CT at 39 months, right? Some sort of the small regrowing of the facet and lamina there, but still decompose very well. You can see the time, clinical outcomes over the time, 156 weeks, right? What of the long-term follow-up? As you remember, my very first case was 2012. I have some sort of the follow-up cases more than 10 years. You can see the 3-4, young 3-4 disc herniation. I did the endoscopic foraminotomy discectomy at this level. 2015, this is CM fluoroscope. Right, post-op MRI 1 year, no the muscle damage. I followed this patient almost 10 years. So look at this. This is pre-op X-ray. Patient had the kyphotic cervical posture. This is a post-op, 10 years. He visited me 1.5 years ago, last follow-up. What about a little more challenging? This patient had the history of cervical laminectomy or the top decompression. The problem he had, sudden onset intractable cervical radiculopathy, left side. You can see the operation scar over the neck. Right, this is problem. You can find it. This protrusion at the CT junction here. So I did the cervical foraminal decompression discectomy at C7T1 level. And you can see the pre-op CT and post-op later. Can you recognize the operation wound of endoscope? Yeah? The red one is the conventional operation scar. This is the endoscope scar here. So look at this. This patient is 84 years old. Of course, if you see this kind of cervical deformed spine having the cervical radiculopathy, I would say majority of surgeons probably suggest multi-level ACDF, corpectomy, posterior instrument transfusion, etc. But considering the patient age and the symptoms just coming from one single radiculopathy, this is going to be very affordable, acceptable procedure. What I think. Of course, we cannot restore the whole the kyphotic posture, but it's also acceptable range of improvement, isn't it? So let's see the complication avoidance. This is one of the revision case. You can see the 6-7 disc herniation. Look at this MRI, very broad base. This is a common finding, especially 6-7 level. The reason why I love to evaluate the patient with a CT scan, you can see the very wide range of calcified disc, right? And actually, I don't think it is a good case of the posterior decompression, right? So bony, so in this case, if you want to go further, posterior decompression by endoscope, by microscope, either way, what is the ideal bony decompression? Draw the line, this is going to be ideal decompression, right? More than 50% of facet should be resected. But reality, look at this. This is the position of the endoscope tube placed over the uncoverable joint, right? Uncoverable joint here. This is midline. This is the ideal yellow one. I think the yellow one is ideal placing of the endoscope tube for each different level of foraminoporosity. But reality, I place a little bit more media. Remember, the endoscope has optic, right? 15 degree, 20 degree, and 25 degree. Placing this this endoscope like that manner, you are not able to lateral side, right? Very challenging. So that is why I made an incomplete decompression. Eventually, this patient, I got it the AC depth 2 months later. One of the challenging, every single patient, this patient had experienced a bleeding issue because he had a history of mitral valve replacements, taking the medicine warfarin. He has ankylosing spondylitis and rheumatoid arthritis. 2017, 9 years ago, I did the operation, right side decompression, but there's a new symptoms happen. So new target came up because he complained of the root symptom left side. Look at foramen at 5-6. That is a problem at the patient. So because this patient has the ankylosing spondylitis and rheumatoid arthritis, the ideal cervical procedure is going to be circumferential fusion, right? But this patient has a high risk of bleeding, so I didn't want to make the serious complication so far. So what's your opinion for this patient? Of course, I did endoscopic foraminotomy. This kind of thick spinal process doesn't matter because endoscope could be controlled even in underneath the thickened cervical spinal process. Because this guy underwent twice. The first one, microscope tube decompression, right side. Second one, foraminotomy, left side. I asked him 3 questions. What about your post of pain? What about your post of improvement compared to that of microscope? What about general satisfaction? He answered me, yeah, I'm gonna say the endoscope is winner than the microscope's decompression. This is patient-driven surgical outcome. So regarding the sagittal alignments, look at this. Patient has, remember, ankylosing spondylitis. This is an 8-year follow after decompression right side and left side. There's no the aggravation of the cervical parameters. So my indication for cervical endoscopic foraminotomy, I think the best indication is stenosis, the soft disc pathology. And also the calcified disc, especially broad-based, you can do it. I can say it is still a good indication, but should be cautious. Regarding the junctional problem, I think that there is also a good indication. So others, the multi-level and CT junction, you should be careful, but you can do it as well. So take-home message. Posterior endoscopic cervical foraminotomy is one of the best way not to make any serious complication related to anterior spinal surgery. Also, it is very effective to treat the cervical radiculopathy, especially low cervical and even CT junction. But I don't agree PCEF is kind of gold standard. It's kind of the plan B option. I love the navigation to assess this posterior endoscopic cervical foraminotomy to determine the accurate entry point and also sufficient decompression, especially the low cervical and CT junction. So not good, but the best. Avoid not bad, but the worst. That's the message. Thank you very much.
Thank you very much.